We will we'll get started, and inshallah we'll have more attendees to join. Thank you everybody for gathering, and today we're going to have our return to our international tumor boards with the American Board Certified Doctors for Egypt. I truly appreciate all the panelists and the attendees, and special thanks to our case presenters today. We have two quite challenging cases that we will go over, and this is an open forum of education. Questions are expected to be asked, and opinions to be shared amongst the group. We are all here to learn from each other and to exchange the way each physician views the care and plans their management. Dr. Manar, our first presenter will be
Dr. Tasneem.
Dr. Tasneem. All right, Dr. Tasneem, do you mind start by sharing your screen? Yep, we can see it now if you want to. Perfect.
Assalamu
Thank you
alaikum.
very much, Dr. Tasneem.
Tasneem.
Yes, we can hear you.
Okay. Yeah. Good evening, doctors. I'm Tasneem Muhammad, medical oncology resident at the Oncology Center at Masuna University. I am honored and glad for the opportunity here today to be presenting to you this case that was presented to our facility at the at our university. The case was a case of hepatosplenic T-cell lymphoma. Mr. EA, a 30-year-old male patient, was first presented to us on the 22nd of June, 2023, with left hypochondrial pain and these symptoms. Patient, according to history, was medically, surgically, and family history was free. Regarding the clinical examination, patient showed hepatosplenomegaly, no evident palpable peripheral lymphadenopathy, and no petechiae or ecchymosis all over his skin. The basic laboratory test shows his CBC showed isolated thrombocytopenia with total leukocyte count of 10, hemoglobin 13.5, and platelet 18. Chemistry, SCEPT was 31, SCOT was 50, bilirubin in total was 0.5, serum albumin was 4.1, creatinine was 1, and uric acid was 13. His LDH rose to 1,474. Basic virology lab, his hepatitis surface antigen negative, hepatitis C virus antibody negative, and HIV 1 and 2 antibodies were negative. Common with these cases are the HLH, so some basic labs were withdrawn. The triglycerides were high for 187, ferritin and fibrinogen were normal. Also regarding the contests, direct and indirect, were both negative. Basic radiology was also performed, and his chest was completely free. His pelvic abdominal ultrasound revealed an enlarged liver reaching 20 centimeters with homogeneous bright echo pattern, no dilated intrahepatic biliary radicals, no hepatic focal lesion, and the average caliber of the common bile duct. Portal vein was patent with the hepatocytic flow and was 13 millimeters in diameter. The pelvic abdominal ultrasound also revealed a marked enlarged spleen reaching up to 23 centimeters with homogeneous echo pattern and no detected focal lesions. His echo was in a normal range for his age. Ejection fraction was 67%, only revealing mild pericardial effusion with maximum thickness reaching up to 0.8 centimeters with no signs of tympanic. Further radiology was done on the abdomen. A CT was performed, revealed an enlarged liver with homogeneous CT texture, no focal lesions or contour irregularities. The spleen revealed was hugely enlarged spleen. The span was reaching in the CT up to 35 centimeters, reaching down to the right iliac fossa. It shows also an ill-defined serpiginous hypodense area near its upper loop, measuring about 13 by 6 centimeters, associated with a small subphrenic fluid collection measuring 4.7 by 1.3 centimeters, aqueous splenic infarction. Patient with the clinical assessment was asymptomatic regarding the splenic infarction, and it was noted insignificant till further assessment. Multiple enlarged eccentric lymph nodes. The largest was seen at the right paracolic region, reaching up to 11 by 8 millimeters. Now we went to further investigation, and we decided that we will perform a bone marrow aspirate for the patient. The bone marrow aspirate was normocellular. All series myeloid erythroid were normal and mature. Megakaryocytes were also present and mature. However, the bone marrow aspirate revealed an immature lymphoid cells reaching to 30%. And immunophenotyping was done on the bone marrow biopsy, and the biopsy was somehow hemodiluted. However, the comment was 25% of the bone marrow cells are lymphocytes that are characterized by increased side scatter and forward scatter properties that express CD3 was bright, CD7 and CD8 were dim to negative, moderate enhancement for CD20, TCR, gamma delta, and CD45. However, it showed negative for the panel was all performed for this patient because it was a rare case and the clinical pathology team was somehow confused with this case. It was negative for CD5, CD18, CD4, CD34, CD117, CD19, CD10, CD79, the MPO, CD25, CD56, and CD57. The conclusion was that the immunophenotypic result was a diagnostic of a TCR gamma delta T lymphoproliferative disorder. The bone marrow biopsy was also small that was taken. The cellularity was about 50% with the tree lineage hematopoiesis were evident. The immunohistochemistry performed was somehow limited. CD3 highlighted the groups of T lymphocytes, and it showed negative results for CD20, TDT, CD34, and CD117.
If I may stop here for a second, Dr. Tasneem. Dr. Alkawaz, from your impression so far, I know we don't have the morphology, but would your conclusion be similar based on the immune phenotype of this population to be a gamma delta T lymphoproliferative disorder?
Yeah, I was a little concerned when they said it looked immature, but there's no CD1A, there's no TDT, and the markers, the loss of 5, the DIM8 and loss of 4, hepatosplenic is usually have no 4 and 8, and so it fits with hepatosplenic so far. The main differential for hepatosplenic is an LGL, gamma delta LGL, but this is a very sick patient, so I think hepatosplenic fits better.
All right, thank you.
The patient clinically, he is fit. He's a 30-year-old young male patient. All his complaint was only the sensation of fullness in his left hypochondrium and some slight B symptoms. Otherwise, no evident bleeding from the orifices or BTK or ecchymosis. According to the NCC, we reviewed the case in our panel for the medical oncology team, and we reviewed the NCCN recent guidelines. And according to the plan of treatment, we started the patient received the ICE protocol in the 12th of July. We started the dose with 25% dose reduction because his basic CBC was platelet were only reaching 13. So was a higher staff consultation that we would consider only 25% dose reduction with a daily frequent platelet transfusion. The patient.
Let's stop here for a second. I know it's more or less center-dependent decisions, but I wanted to talk with our panelists and see from a treatment plan, Dr. Gaballa, what would be your preference in frontline therapy for these patients?
Thank you. So the problem is the hepatosplenic T-cell lymphoma is an extremely rare entity. As a matter of fact, I've only come across maybe 1 or 2 cases. There's no one agreed upon standard of care, but in general, CHOP is suboptimal in those situations. So at least where I practice, we would recommend something like hyper-CVAD, but Other aggressive regimens are also, reasonable. Dose adjusted epoch could be, could be considered. ICE is I mean, was there one specific reason they picked ICE? I mean, I think it's reasonable. I'm just the problem is there's no standard of care, so it's really center dependent.
Our rationale behind using the ICE protocol is that we reviewed the recent NCCN guidelines, and it was the first recommended regimen for treatment of such cases. However, hyper-CVAD, dose-adjusted epoch were also preferred regimen if the case was refractory.
Okay. Yeah, no, I mean, I think it's reasonable. There's no standard of care, so it's one of those situations where you could, you have a few options to pick from.
Well,
The patient received his full cycle.
May I have a question? Do you hear me,
Please.
Dr. Muhammad?
Please, تفضل Dr. Nasser.
While the thing is that did you want to reduce the dose by 25%?
Excuse me, Dr. Muhammad?
So the question is, why was the dose reduced?
Why did you reduce the dose of the 25%?
There was no clinical base on the dose reduction of the patient. However, the patient's CBC showed severe thrombocytopenia. It was 13, and there was some concern about the aggressive dose of the ICE protocol, keeping in mind that patient's surface area was almost 1.9. So only to start the treatment, it was a decision taken to begin the first cycle with 25% dose reduction. Otherwise, no clinical reasons for that. Scientific basis for that.
Thrombocytopenia?
I'm sorry, Dr. Mabed, can you say that again?
But I think that you have the bone marrow. It was okay. The bone marrow?
Yes, the bone marrow biopsy was not impressive, right, Dr. Tasneem?
Yes, it revealed normal aspect. The megakaryocytes were present and mature. Nothing suggesting dysplasia or anything in the megakaryocyte series.
But it has lymphocyte infiltration.
Okay, so go ahead.
Would you have dose reduced, Dr. Mabed, with these findings or no?
I will not reduce the dose.
You would not.
Yeah.
How about Dr. Gawalla? Would you dose reduce based on the CBC starting therapy?
So it's a bit unclear to me. So the dose reduction was because of the platelet transfusion requirements?
Because the CBC was low. The counts were low on the CBC.
Yeah. And was he transfusion dependent, or is it just
Yes. No,
how?
he was transfusion dependent. His platelets reached to 7 for these numbers, and he was on continuous platelet transfusion daily, platelet transfusion from 4 to 6 units daily.
Oh, I see. And the bone marrow, did it? I mean, I know there were some lymphocytes, but was it like a packed bone marrow, or my understanding is it was not packed bone marrow, right?
No.
Unfortunately, the biopsy was taken was small somehow, but nothing suggested. It almost 20%. Yeah,
no, I think you took a clinical decision based on what was going on. I mean, from what I'm hearing, I probably would have not dose reduced. But again, I don't. I mean, if the platelet functions improve and whatnot from starting cycle 2, you could go for the full dose. I don't think that's going to be an issue. Now, let me ask you a question: was the T cell receptor gene rearrangement done, or was not that was not available? Not available. Okay. All right.
So a couple comments. The distinction should be made between thrombocytopenia related to splenomegaly and that related to production in the marrow. There did seem to be trilineage hematopoiesis preserved pretty well in the marrow, and that's the thing you worry about, of course, with chemotherapy. So given that the marrow seemed to be relatively involved but not specifically affected, and that we think the splenomegaly is perhaps the major component of the thrombocytopenia, then you may be more justified in giving full dose therapy in that circumstance, given that you don't think this is necessarily a production defect as much as a sequestration defect related to the splenomegaly.
Totally agree. Totally agree. The spleen is likely where it's all kept. Sounds good. Dr. Alia, what's your take on this decision as we move to the next step in the patient's management?
Hepatosplenic T-cell lymphoma is commonly accompanied almost always having patients having thrombocytopenia. But I think it is not it was not wise to reduce the dose. I think the patient will get benefit from full dose ICE protocol. But I think this decision based on non-availability of platelet transfusion within the cycle, so we are fearing of bleeding. We give the patients holoxane high dose, so we may have hemorrhagic cystitis, hematuria. So I think dose reduction, it is not wise, but it is inevitable.
I see.
Several other quick comments. One is most of these patients have antecedent immunosuppression for one reason or another prior to their diagnosis. Did this patient have any autoimmune disorder or any evidence of an immunosuppressive disorder prior to the diagnosis?
Yes, it's very important point missed from the history of the patient. We should ask the patient about history of immunosuppression, history of inflammatory bowel disease, Crohn's disease. And so before starting chemotherapy or medical treatment, you should ask the patient to reduce immunosuppressive agents before doing or before giving chemotherapy. I don't know if you ask about that, Tasneem, or not.
The patient medical history was taken a full medical history, and he stated that he didn't complain of anything all his life, and he never treated or took any treatment before.
Do you happen to know if he was we tested him for like HIV?
HIV, yes, we did the HIV 1 and 2 antibody, and they were negative.
Okay.
With
I mean, I
regard-
think let's move on. You know, the issue about the immune, the 20% dose reduction, I think in either case, I mean, it would be, they just had to take a clinical decision. I don't think it's going to be like a, that it's going to make a huge, difference up front, but let's just see what happened.
We went protocol in 12th of July, and we put the patient out in the outpatient clinic for following up of the CBC after 2 weeks. The total leukocytic count revealed a count of 3.4, neutrophil was 1.3, hemoglobin 12.6, and platelets now rose to 38. Patient was not on any platelet transfusion outside. Clinically, the patient reported improvement in the left hypochondrial pain, resolving of the toxic symptoms, and regression in the splenomegaly. After 21 days of the first cycle, we commenced a second cycle of the ICE protocol. Also, 25% dose reduction and platelet transfusion. We continued at the first, and the follow-up after 21 days of this second cycle. Clinical assessment revealed again the patient began to complain of this left hypochondrial pain, here splenomegaly. The CBC revealed was the total leukocytic count was 4.1, hemoglobin was 11 with homocytic non-chronic anemia, and platelet was 13. Other bone marrow evaluation was done. His bone marrow aspirate now revealed an infiltration by the large immature lymphocytes by 29%. The bone marrow biopsy were also fragmented to samples, small samples, with average cellularity 50 to 60% with positive CD3 and about 20% of the cellularity. With a microscopic examination, revealed large cells.
Dr. Alkawaz, is the gamma delta T cell a large T cell population in general when you describe them?
They're not large. They're considered medium sized. One thing that should always be ruled out is anything that's EBER related. So I didn't see anything that has to do with EBER, because one of the main differentials is like an aggressive NKT cell disease or just an NK disease. But they're not usually large, just to respond to your question.
So now the discussion part of our presentation. According to your opinions, what are your suggestions for the plan for salvage treatment?
So I'm sorry, how old is this patient?
30 years old.
Okay. Yeah, I mean, one of the main concerns is, I mean, obviously, the issue is, are we 100% sure, of the underlying diagnosis? I'm just not very comfortable with with the large cells that you're describing. I mean, I think that's just like you couldn't like put the get the pathology slides reviewed, the pictures, right?
The comment was
No.
Yeah.
No, we
Yeah, I
don't
mean,
have it.
that's just like the problem because, I mean, if we're talking about a relapsed or refractory, hepatosplenic lymphoma in a 30-year-old and is like primary refractory to, chemotherapy, I mean, the outcome is going to be, not good at all. You would consider salvage therapy with, another regimen that they have not seen, something like, I probably would pick hyper CVAD. And then if they achieve a CR1, you would try to take them for an allogeneic transplant if they're, 30 years old. The only issue is obviously if, there is, because the problem is, hepatosplenic T-cell lymphoma is such an extremely rare entity. So it could be sometimes, confused with, other things. So you have like NK T-cell lymphomas. I mean, it doesn't sound like this is like a TALL or a lymphoblastic lymphoma. I mean, these are just like the things in the differential that we need to rule out, but because obviously those also, you would treat with a more aggressive regimen. But for this case, I probably would, maybe choose hyper CVAD. I mean, you could also do dose adjusted EPOC. I mean, something that anthracycline based, I think would make sense. You do need like to make sure they do like an LP and make sure there's no CNS involvement. But I would probably just make sure you review because it's like extremely rare hepatosplenic lymphoma. So these are I mean, even if when I see them here, those are one of the situations where we would send them for like a second opinion pathologically speaking. Just to confirm, because if there's an issue with the diagnosis, the treatment is going to go in the wrong direction.
Sounds good. So we have one vote for hyper CVAD. Dr.
Having said that, it did have the classic flow characteristics of this, and the original pathology certainly seemed entirely consistent with enlargement of the liver and spleen and not much adenopathy or really much else, no TDT, no evidence of immaturity. So notwithstanding the impression of larger cells, it does sound like this is it. And it's not entirely surprising that he would bounce off dose-reduced ICE. That's not very strong therapy for a very aggressive lymphoma. There are a number of different choices. I'll put this in the comments, this paper that looked at alemtuzumab and cladribine. At least there's one case report of somebody who couldn't get a transplant going into complete long-term remission with that regimen. So it's not as intensive, but it might be something that could be done there and maybe have a better chance of not necessarily having to go on to do transplant and not having to give more intensive therapy. So for your consideration, I certainly agree that generally speaking, a young otherwise healthy person would get aggressive therapy. And per both, I think, the MD Anderson and European Consortium opinion, there's an opinion that allo is better than auto in this circumstance. But again, it's a handful of patients that we're talking about, case series of like 18 folks. So we don't really have the best data for this. But if we don't have a transplant to look at, this might be a regimen to take a look at other than other more aggressive therapies that have been discussed.
So let's say you're going to make your vote with one regimen. Now you have ICE that was dose reduced, patient bounced very quickly. Would you call that a failure and move to alemtuzumab cladribine, or would you go to a more intensive regimen such as hyper CVAD, full dose without any dose reduction?
Are you asking me, Mo? I'm sorry.
Yeah. Because he's 30 years old. I'm thinking I'm not saving any effort here to last.
Here's the tyranny of this. If you're not going to go to transplant, auto or allo, then what's the data for any of these things? Essentially, all the United States data, when you push dose, everybody's going to transplant in this disease.
But why are we seeing he's
May
not
not-
a transplant eligible? He's 30 years old.
Well, because I understand in Egypt, not everybody is able to go. That was the discussion I remember at the last international meeting.
No. I think they do have the capability. I mean, I was there
Oh, okay.
before, and we do
But it's
allos.
auto transplant, I think, not allo, correct? Is
No,
there
no,
a
no,
protocol?
No, it's
No,
there's
allo
actually-
can
No,
be done at
Oh,
some.
okay. Well, then I would certainly pursue aggressive therapy and try to get him to allo transplant. Yes, indeed, if you can do that.
Yeah.
Yeah, I mean, you know,
the alemtuzumab regimen is not. It's not easy to get here.
We have no alemtuzumab in Egypt. We may use calidropine. I think hepatosplenic T-cell lymphoma accompanied by JAK-STAT pathway abnormalities. So I think the patient may get benefit from carfilzomab. And no line of treatment will be of benefit except for transplant. So you may prepare your patient for transplant. This patient should be transplanted.
Yeah.
If we have the choice between the auto and the allo, so we'll prefer which one?
I prefer allogenic transplant, but both regimens or both types of transplant documented or mentioned in treatment of these cases, either allogenic or autologous transplant. But I do prefer to do allogenic transplant.
Yeah, Dr. Let me ask if the splenectomy, any rule the management of this patient?
Splenectomy for just palliation of symptoms, not a main line of treatment like marginal zone lymphoma or like that. But we can do splenectomy, but as a palliative line of treatment, not as a curative intent like chemotherapy or target therapy or transplant.
Yeah, I don't recommend
Parking.
At all in these patients because of the complications and the risks that they get from the surgery itself. It comes with risks. So I can't say that we see a lot of gamma delta T cells, but I would agree that allo transplant is the way to go in those patients. I think we will have a lot of controversy depending on the donor type and the conditioning regimen and the GVHD prophylaxis regimen. I wonder if we don't have enough data, so this is a data-free zone and a discussion based on other diseases, how you would approach them. So Dr. Gaballa, in Moffitt, the T-cell lymphomas, if we go, rather quick, I don't want you to elaborate too much, but if we have, let's assume we have a matched related donor here. What would be the typical recommended conditioning regimen in a patient like this?
Yeah, so I mean, I've kind of like moved away from transplant over the last few years, but this is again one of those things that even within the same center, you might have people doing different conditioning regimens. I think in general we'd use like a reduced intensity conditioning. But I don't, I mean, even, different centers will use different things. Like, you have busulfan centers, you have, when I was in Philadelphia, it was all TBI based regimens. Moffitt is mixed. So there's a group of, Buflu, people similar to MD Anderson. There's also Flu-Mel, conditioning. TBI is not very common, but I think for this situation, probably, I mean, it depends on who's gonna, see him, but I think probably something like a Buflu would probably make sense.
All right. Dr. Emmons, what would be your take? I saw you shared a link or an article.
I did, because the European Consortium is the biggest publication I could find of series of patients like this that compared auto to allo. And most of those patients got aggressive conditioning, not many transplants. And most of them are, of course, young, because young adults get this. The complication with this is that most of the patients who get this are already antisatent immunocompromised, and depending on their degree of immunocompromise, you can either cure or not cure their immunosuppression with the transplant. So if somebody comes into, auto transplant and they have an underlying genetic basis for immunosuppression, you may be killing two birds with one stone by doing an allo transplant, replacing their immune system to give them better immune support overall and preventing, therefore, the progression of their T-cell lymphoma. In this guy, we don't really have evidence that he had an antisatent immune cell disorder, which is perhaps in his favor overall, but certainly he bounced off ice, the reduced dose. So, you're sort of in a bit of a quandary here. Do you press ahead with chemo, and which type of transplant do you do? There is evidence from that paper that some patients can do well with auto transplant, but again, in general, the European Consortium recommends allo in this circumstance. But again, they may be recommending allo, and those patients may do better with allo, not just because of the T-cell lymphoma, but because of their antisatent immune suppression that may be genetically based as well.
Mm-hmm. Dr. Tasneem, did you start the typing process, HLA typing, to see if what's the donor status for the patient?
Yes, we actually began the procedures. We have long procedures somehow in the governmental hospitals, but the patient has two older brothers and one younger sister, and we began we were pending the results for the matching with his older brother. So the brother is about 40 years old, and we are pending the results for them.
Why are you going for the older brother? Why not the younger brother?
It was a family thing, a family decision.
Oh,
But,
okay. I see.
Is that an Egyptian thing in terms of the older brother having the greatest responsibility in the family and therefore stepping up to the plate? Or am I reading that wrong culturally?
I would like to know.
Maybe something in particular to this family, but usually we have different choice. Sometimes the older one they refuse the donation. Sometimes the sister refuse the donation. So this dependent on some foundation.
Medically wise, both were fit and both were medically free. So
how young is the younger brother?
I think there was differently, like 40 years old. The second brother was like 38 or 35 years old. The younger sister was about 27.
Okay. And the sister did not have any kids yet, do you know?
No, I think she's married. She's married. She's
married.
I don't know.
She had kids.
Okay.
Can I ask a question?
Please.
Does the patient have to be in complete remission before going to allo, or if some residual disease present would be a problem?
If he's not, then probably not to do a mini conditioning regimen, and there you might want to choose TBI to help get that remission that you need to potentially overcome that problem.
Yeah, just like Dr. Emmons said, ideally CR and an excellent partial response, a very, very good partial response might also be that there is a lot of data on T-cell lymphomas and other non-Hodgkin's lymphomas in the B-cell side that the reduced intensity is mostly the better outcomes compared to ablatives. But when you are going with residual disease, you're going with a high chance of relapse. So ideally, you want to bring the patient to CR before going for allotransplant.
Yeah, I agree. I completely agree.
Your recommendation on the conditioning regimen.
I think Dr. Gaballa mentioned Flu-Mel is one of the regimens that they use over there, Flu-Bu2 as well. Flu-Mel sounds good to me. And that also depends on the donor source, right? Like if you have let's say you have a haplo, you don't have a full match, then your choices of regimens change, and you need to incorporate some TBI and flu-mel TBI is a regimen that when you don't want to use flu-cy TBI, which is the standard haplo regimen, if you want to amp it up a little bit, flu-mel TBI has been studied both in, I'm not going to say in gamma delta because I haven't seen any data in that realm, but in non-Hodgkin's and T-cell lymphomas, there are studies with flu-mel 70 and flu-mel 100 TBI for haplotransplants. I'm not sure what Dr. Emmons would recommend in this patient, let's say matched, one of them turned out to be a full match, or if they are haplo donors.
Yeah, if it's a full match and you have complete remission based on everything that you can determine in the marrow and in the blood, I think dealer's choice as far as a mini regimen. I don't think there's any evidence that flu-cy over flu-mel or any of these other mini regimens would be necessarily superior. But anything less than that, then I think really the extra kick from a little TBI before transplant to help get a better remission and try to prevent early relapse might be reasonable.
Excuse me, I have a quick question. If our patient actually turned out to be not having a fully matched donor, so his potential donor is haplo donor. So when we're choosing between haplo and autologous transplant, so would we proceed with haplo?
I will proceed with haplo transplant.
I would think the data is very scarce in this realm, but it's still when you look at the consortium data that Dr. Emmons shared the publication with, quite a bit of it were matched siblings and unrelated, not a whole lot of haplo, but what we have is data on long-lasting remissions in this disease are almost limited to allotransplant with limited success in autotransplant. So I would agree with Dr. Sergani that I would go with allotransplant. You might want to work on the immune suppression, tapering, be a little bit more aggressive in getting the patient off of it. We are now using post-transplant Cy in almost everybody, so I can't back that up in this disease, but that's what we do is post-transplant Cy plus TAC and CellCept, and that's it.
Thank you.
Of course.
I did find one publication of a successful haplotransplant for gamma delta T-cell lymphoma, and I'll put the reference in the link.
Wonderful. Thank you very much. That's a good case. It took us 41 minutes, and the next case is we're done with this one, right?
Yeah, I just want to state that we went indeed for the hyper-CVAD protocol. The patient started it in 20 of September. Again, first one, and he was presented yesterday to us with the ER with febrile neutropenia with neutrophil 0.9 and platelet showing a count of 7. He's now in the febrile neutropenia protocol, and he's getting better in transmission. Okay.
One thing I will say, I don't see the role for dose reduction here.
Okay.
I don't see it. I understand the concern about transfusion needs, but that's not what's going to get us there. We're talking about the hypothetical risk of bleeding with very low platelets.
Yeah, began with platelet 4.
Yeah, but what we are seeing also is extremely lack of response with ICE as it was used as a dose reduction. It didn't do any benefit to the patient. So I would strongly encourage that if we're going to do it, let's do it by the book, so we have a chance. And possibly this already started, so in 1B, methotrexate and RSC of hyper-CVAD, not a whole lot of concern there, not very it's not as myelosuppressive, so you might not need to do that, and then hopefully the platelets get better after this cycle, so you can go back up to a full cycle.
Okay, and do you recommend doctor evaluating after the second cycle, or we should go further?
Yeah, we don't assess after 1A. It's too quick. Yeah, I would the reassessment will be combined by the improvement in counts, overall symptoms, as well as restaging with images. I would out of curiosity get a scan after 1B, but the official would be after 2B.
Okay.
Yeah, and I will also get a bone marrow biopsy. If you're, I mean, you have enough time between now and to get the identify the donor, and just make sure you have the coverage and whatnot for the allo. But before the transplant, you would need imaging, a bone marrow biopsy, preferably a PET CT and a bone marrow biopsy. And if it's in CR, to try to proceed with an allo. I agree. I mean, if there's no matched sibling, I would choose a haploidentical donor over autologous transplant. The reason is, long-term remissions with autologous transplants. Autologous transplant is really just chemotherapy in this setting, and long-term, cures from auto transplants is lower. The problem with these, consortium data usually is they're retrospective, so it's not very. I mean, it gives you an idea, but sometimes you would see increase. I mean, you would always see increased non-relapse mortality in the allo group, and in the auto group you would see higher rate of relapse. So sometimes they might seem equivalent, but for someone who's 30 years old, relatively young, I would definitely try to give him a chance with an allogeneic transplant, even if it's a haplo. The mostly haplos now with post-transplant cyclophosphamide, the graft versus host disease rates are lower, and they seem to me very similar to either matched unrelated or even approaching those of match related.
Wonderful. Thank you very much.
Thank you.
Thank you, Dr. Sneem. Thank you, Dr. Gabel, Dr. Emmons, Dr. Sugani, and Dr. Mabed. Well, let's go to the second case. The second case is going to take us over time. I'm just a disclaimer right now. This is a longer case. This is a very interesting one and a tough one. So let's go through it. I will save all the questions and comments until the end so we hear the whole story. Who's presenting the next case, Dr. Manor?
Dr. Malaka Awad. She's with us.
Thank you, Dr. Malaka, and I see your slides. Go ahead. We can't hear you if you're presenting.
Assalamu alaikum. I'm Malak Awad, Assistant Lecturer of Hematology. It's a great honor to participate in this great event. I will talk about the case of refractory relapsed AML post-transplant.
Wonderful. Thank you.
Can you hear me?
Yes, we can hear you.
Yeah.
Can you put it in presentation mode, please? The slide. We can see them, but just you can.
Okay.
Load up.
This male patient was 29 years old, was diagnosed and treated at Kuwait in June 2022. It was presented by CBC, show leukocytosis, white blood cell count was 150, and thrombocytopenia. Tumor aspirate showed 82% plus cells. Immune phenotype.
Dr. Malaka, that we don't see the slide except for the first one. If you may.
Yeah, you might be just try to share the PowerPoint.
Okay, I will reload it.
Okay, perfect. Now I can see. Now it shows. Yep.
Is it clear now?
Yes.
Yes.
This male patient was 29 years old, was diagnosed and treated at Kuwait in June 2022. He was presented at the first time at Kuwait with CBC show leukocytosis, white blood cell count was 150, and thrombocytopenia. Boomer aspirate was done, show 82% plus cells. Immune phenotyping show it was positive for CD13, CD33, CD34, CD117, CD64, HADR, MBO, and it was consistent with case of acute myeloid leukemia. Bone marrow biopsy was markedly hypercellular bone marrow. Cellularity was 100%. Showed diffuse infiltration by blood cells about 80%. The blood cells was positive for 34, CD 150, 117 MBO, and was negative for CDT, CD79A, CD3, CD5, and CD20. And it was consistent with acute myeloid leukemia with minimal maturation. Cytogenetics was done and show a normal karyotyping, and 11q23 arrangement was positive, so the patient was classified as high risk AML. Molecular was positive for KMT2A fusion. It was detected at 100%. The patient underwent one session leukophases with hydroxyurea. Then the patient received daunorubicin, citropin, daunorubicin for 3 days and citropin for 10 days on 29 June. Bone marrow aspirate on day 14 show 45% plus cells, and the CBC showed delayed recovery and impending septic shock, but the patient improved. And boomer aspirate on day 21 show complete remission, 22% plus cells. And the flow show 4% plus cells. So the patient received daunorubicin RC 8 days protocol on August 2022. Then the patient underwent neutropenic fever with growth factor support. Peripheral blood film also show plus cells, and the boomer aspirate on 31 August show a complete remission, 2.7% plus cells. Then the patient received one cycle high dose RC on September 2022 and started planning for allogenic bone marrow transplant. MRD was positive by 0.1%, and the bone marrow team recommended further high dose RC then for new MRD. Patient received second high dose RC on 2 November, and the MRD by cytogenetics KM2A was negative. And the patient was having two matched donors, his sisters, and underwent allogenic bone marrow transplant from his sister. Received the conditioning regimen, oral busulfan from day -10 to day -7, 1 milli per kg every 6 hours. And cyclophosphamide 30 milli per kg per day over 2 hours from day -5 to day -2 with Misna, and the cyclosporin 1.5 milligram per kg every 12 hours from day -1 to day +1. Then dose adjusted according to trough level, and received methotrexate IV from day +1, 3, and 6, and 11 with calcium glucophorine support. Stem cell infusion was on 9 January 2023. During the patient receiving conditioning regimen, the patient developed leukocytosis. The TLC count reached up to 20,000, and the blood film show 18% plus cells. The bone marrow team during this period suggest continuing the conditioning regimen and continue for allogenic bone marrow transplant. البيشنت after allogenic bone marrow transplant the bone marrow aspirate show 1% plus cells and it was in complete remission. الchimerism analysis for 6 mismatch after bone marrow transplant was 100% XX on March 2023. The blood group after bone marrow transplant changed to O positive blood group of donor. Then the patient did bone marrow aspirate on March 2023. It showed 20% plus cells. Then the patient received the flag protocol on April 2023, and the bone marrow aspirate after that showed 64% plus cells. Then the patient received 2 cycles Vidaza venetoclax. The first was on May 2023, then the second was on June 2023, and the blood film show plus cells in the peripheral blood. We did the echo for the patient. It show ejection fraction 66% and calculate the total dose of Adria received by the patient. He already received 684 milligram. So the patient received cladribine low dose RC with venetoclax on August 2023. Cladribine was in dose 5 milligram per meter square IV from day 1 to day 5. Low dose tropine 1 gram per meter square from day 1 to day 5 with venetoclax 100 milligram. Then the patient developed septic shock and progressive chest infection and decreased ejection fraction and intubated for a few days. Then the patient died. What do you think if there is any appropriate management for this case?
This is a very tough case. The writings were on the wall from the get-go that you have a refractory disease. But just to sum it up, this patient had a KMT2A, MLL rearranged AML, got 2 cycles of induction, right? And you give him cytarabine 10 days. Is that a standard induction regimen that is 3 days of daunorubicin and 10 days of cytarabine?
Oh, he already received this protocol at place.
Is that a standard regimen? I'm just trying to.
No, he received it and quit. I was in our practice were using 3+7.
Okay. Yeah.
Yeah.
Right. Yeah. 7+3 or 3+7. So he got 10+3 and then got an 8+3 before he went to get his HIDAC consult.
You know what? Let me ask. Maybe they're counting the. I don't know. Maybe it's like maybe it was a 7+3 and then a 5+2.
Sorry.
So how many total days of RSC and how many total days of anthracycline did the patient get?
This patient received the daunorubicin for 3 days and RST for 10 days.
10. So 10 the first time and 8.
And 8 for and we don't know why he received the 8 days and second course.
And then was in remission before the second induction, but it was residual disease on less than 5%. Went on to get HIDAC, and
but let me know that Muhammad is at your practice are you evaluating the responses at day 14 or day 28?
In a disease like this patient's, we don't do a day 14 marrow. The day 14 is a physician-dependent decision in our group, where Dr. Emmons, for instance, I'll tell you what he likes. He likes in the good risk people, the chemosensitive people, will get their day 14 marrow in case that we are moving if we're not where we need, we might amp the chemo. But we just get it on a day 28.
Yeah, it's a very controversial. So yeah, I mean, you know, so I've seen like a lot of variations. Like for example, you know, at my previous center, they almost never checked the day 14 marrow because it's always confusing, and it's hypocellular, and you're calling it like, 10 or 20%, but the whole cellularity is like, 5%. So it doesn't make a lot of sense. It's really hard. Where I practice right now, they almost, do it for every patient. The only piece of information that would be useful from a day 14 is if you do the bone marrow and it's fully cellular and fully packed with chemo, then it's a primary refractory and you don't want to wait till the day 28. That's the only time when it's useful. But otherwise, when you see that the cellularity is low, then it doesn't really have any meaningful impact to talk about the blast count when your cellularity is low. But yeah, I mean, the only thing is if you just want to make sure it's not a packed marrow, but it's very controversial. Some people do it, some people don't.
Right.
One piece of information, do we know whether this was FLT3 positive or not at any point?
I don't think was it checked or not?
I guess he was negative because we have done lots of cytogenetics for this patient.
But it won't be possible for cytogenetics. We will need molecular testing, PCR or NGS.
We usually do FASH. I don't think we do PCR in our center.
Yeah, then you won't find FLT3 in those.
So that's not routinely done then in Egypt, is that correct?
Sounds like it's not a routine test, or at least when this patient was evaluated, it wasn't done. Is that the case? FLT3 is not a standard test in AMLs?
No, we do it.
We did it.
We do FLT3 evaluation.
We don't do it for this patient.
This patient.
Isn't KMT mutation is poor risk? Why do we need FLT3?
Well, FLT3 happens in 30% of patients with AML, regardless of whether they have MLL or not. And if he's one of the 30% and he didn't get a FLT3 inhibitor, this could be, aside from the MLL, which is certainly high risk, another very high risk region why he would relapse quickly after transplant. And there's, of course, a blocking drug that would make a big difference here.
Yeah, exactly. I mean, we have FLT3 inhibitors now. So if this, if you have any AML patient, we would recommend checking FLT3 up front because you do have, it's a targetable mutation now, and we have, several drugs that could target it. So in the future, it's something to consider. Yeah.
We already do FLT3 mutation for our patients initially, but I think these patients did his investigations equate. Not in our center. I think it is missed already.
Oh, yeah. Even at relapse, if you have a relapse and you don't know if it was done initially or not, you probably may consider. I mean, in all honesty,
in this case, we would do FLT3 IDH1 and IDH2 because you're in a bad situation now with a relapsed person post-allo. If you've got any of those things to add to the picture, we would certainly try to do that in this setting.
Yeah, exactly. Yeah. But let me ask, is like midostaurin and gilteritinib are available in Egypt now or no?
No, we don't have
available.
Sorafenib, the only available drug.
Sorafenib.
That's
unfortunate.
So Dr. Mohammed was saying that in the patient relapsed with survival, he was receiving his preconditioning regimen. So any recommendation for I don't know, the interference by that point? In addition to the PSI, he was receiving the lymphocytins and cyclophosphamide. After receiving the 4 days of lymphocytins, he showed the lymphocytosis and blast cells in peripheral blood.
It's very difficult. We have a patient relapsing in the middle of the ablative conditioning. I would have done what you would have done, which is continue to blast the chemo with the conditioning regimen and try to get rid of the GVHD prophylaxis and do a preemptive DLI. as early as day 60 post-transplant and run the risk of having GVH in an attempt to try not to have a relapse. It sounds like the patient, the evidence of relapse here was how many days post the biopsy assessment was how many days post-transplant?
I think the only
I think you relapsed
day
2
30,
months. Oh, yeah. Day 30 something.
the assessment is for the
30 days.
Yeah, I mean, you know, so even if you take an AML patient with active disease, I mean, we don't usually do that a lot. But if you take an AML patient with active disease, you could still cure about maybe 20% of these patients. And I think it was like, what, 2 years ago at ASH, they presented the data from Europe where, you know, they had these patients going to allogeneic transplant with active disease. And I mean, it seemed to, I mean, I don't do a lot of AML now, so Dr. Muhammad, maybe you could comment on this, but the outcome seemed, you know, interesting, where, you know, they were suggesting that, you know, maybe we could be a little bit more, you know, liberal in taking these patients with active disease to allogeneic transplant. I don't know if it made any practice changes at your center. I mean, it didn't do anything at our center.
No, it hasn't changed. The comparative arm was not a comparator that we typically use. Most of the regimens that they were using were different. But I agree. I would have continued. I don't know what Rob, what do you think? Would you have continued with the conditioning regimen, or would you put brakes and did something else if you were?
Well, again, I mean, you know, FLT3 and IDH1 and 2 are critical in this circumstance. If you've got, I mean, even with sorafenib, if you've got sorafenib and you've got a FLT3, that would definitely be part of any kind of regimen for this person at this point. The other aspect I didn't completely understand, please help me understand. Did this patient truly have 3 different MLL mutations? I saw the cytogenetics showed 1 and the FISH showed 2 separate ones. Is that correct? Were there really 3 different MLL rearrangements in this leukemia?
I saw the 9 and
the cytogenetics seemed to show a 611, and then FISH showed a 911 and an 1119. Is that true? This person had 3 different, because that's pretty important too. That's a terrible disease. I mean, it's bad enough to have 1 MLL rearrangement, but having 3 separate MLL rearrangements is a real terrible thing as far as genetic reality for this patient.
It's possible that it was reported as abnormal, the FISH probes, because there is a break apart in the MLL, and that was interpreted as the actual probe being abnormal.
Go back one more slide, if you would. One more, sorry.
First report, yeah, that one.
Yeah, so this one showed a 611 on cytogenetics, and then on FISH, there was a 911 and an 1119. Mustafa, what do you think of that?
Yeah, what I'm saying is I would go with the karyotype. There is a possibility that what happened is that the FISH probes were atypical because of the rearrangement in the MLL, but not necessarily, or the KMT2A, but not necessarily the partner. And I think it says 911. I think it says 911 and 1119 are negative.
Is that what it says? I'm sorry, I misinterpreted that. It just said
I think so. I think so. But
negative.
Yeah.
I see. My fault.
Oh,
yes. So it is just 611.
11 is the only positive finding. 11,
Yes, thank you.
19.
Thank you.
Thank you.
To share something, it's more of academic interest right now, but it will be standard practice. So there is a menin inhibitors. They are currently in clinical trials, and there's a couple of them that is further in development. And one of them, the name is a little funny, called ziftomenib. Ziftomenib is a menin inhibitor that showed quite an impressive response in KMT2A mutated, like MLL rearranged AMLs, as well as NPM1s. specifically mutated AML. In relapse refractory, they might get the approval in the coming 6 months or so, and it will be a late involved drug that might make its way to upfront. This patient is quite unfortunate. I'm just thinking of what we have done as another therapies that can target this bad relapse and refractory disease.
I have a
Can I
question.
comment? Can I have comment, please?
Yeah, go ahead, Dr. No.
Yes, good evening, everybody, and Dr. Noha. I do agree that this patient, it seems he's refractory to chemotherapy. I think sooner the paradigm treatment for AML will be shifted to biologic treatment rather than chemotherapy. Even the center where I am working now, they give salvage biological rather than chemotherapy, even in young adults, big patient, as a bridge for a transplant. So from this patient history, seems not responding to chemotherapy. At the regard, I do agree that this patient should need the NGS and PCR for FLT3 and NBN and as well IDH1 and IDH2. At the regard, the MML mutations, yes, Syndex have just opened the compassionate use for revumenib. This is menin inhibitor for relapsed refractory AML. This will be a future target therapy for such cases. It is actually an interesting case and a challenging case. So I think for this patient, the best is biologic treatment, even as a second line, not necessarily third or fourth. For transplant, they start conditioning and the patient showed leukocytosis and progression. I do agree that we at that point to continue conditioning regimen because already the patient was started and even the prognosis is not as will be as expected. Thank you.
We have the explanation for the resistance to venetoclax. This patient received venetoclax, but actually in a reduced dose. He was receiving the 100 milligrams only, and we to make use of drug-drug interaction with voriconazole. So actually, he received 100 mg. So what do you think about this procedure or this practice?
Yeah, that's how we, if he needed the voriconazole, we reduced the dose to 100 milligram because the effect of the 100 milligram with the CYP31A or the liver metabolism of the venetoclax is different, and 100 milligram will be equivalent to the full dose. If he doesn't need the voriconazole and we can switch him to fluconazole, then we can up the dose to 200 if they don't need any azoles, which is kind of difficult because this is a patient who is post-allo recent. Then they will need to be on some sort of an azole and a dose reduction of venetoclax will be needed, yes.
There was resistance to venetoclax. And I don't know why. Do you have any explanation?
Yeah, we use
mutations, for example.
Yeah, we use donor lymphocyte infusion in relapses in the hope that it might end, but honestly, the responses are not very great. The patients still, especially those who are in full-fledged relapse. That's why this patient, he's already relapsed on day 30. So we had a very, very poor luck with the nature of the disease. But DLI, there is a data we're using where you use Revlimid and hypomethylator rather than venetoclax and hypomethylator, and you alternate 2 cycles of this plus DLI, then 2 cycles on another level of DLI. You keep upping the dose of the lymphocytes on each level with the hope that you can increase a graft versus leukemia effect. but I have to tell you, I have not been very successful, and a lot of people don't believe the DLI do much for the patients.
Do you think that the donor type might have been a contributing factor, as she was a female, fully matched? Maybe if there was a little mismatch in the donor, could add more in the GVL effect?
Let me see what our colleagues think. Dr. Emmons, what do you think about that?
Well, female donors into male increase the risk of GVH and GVL. So actually, it's a relatively helpful thing to have a missing Y. I think, I don't think it's a downside particularly. Now, the full match versus a matched unrelated, there's a little bit of a stronger of a GVL effect. But quite honestly, this person relapsing at day 30 is a kinetic failure. I don't think it made any difference what the relative matching was. You didn't have enough time for the allo effect to take hold and do something in this case. This disease outstripped any type of donor transplant from effectively working. That's again why it becomes important to determine why the kinetics of this is so high. Is this a FLT3 containing leukemia? Because if it does have a FLT3 ITD, then adding sorafenib as part of your regimen is critical, because you're never going to achieve any kind of reasonable remission short of that.
Yeah, okay. So if the patient was alive, what would you do next for him? Is there some sort of CAR-T trials going on?
They don't work.
Yeah, I mean, there are certainly AML CAR-T trials in the world, but those are all very early clinical trial sort of things. And I agree with Mo about the DLI issue. You know, the successful DLIs were mostly published in the age of doing allo transplant for CML, which is a highly immunoresponsive disease. That's where the highest chance of DLI working was published in the original literature. AML DLIs, I agree with Mo, have not really been as successful. But again, this is not really so much an immunologic problem here. This is a kinetic failure. This patient bounced off transplant in less than 30 days. So unless there's some extra hook you can get beyond chemotherapy to try to get a deeper remission, I don't think there's any potential for DLI to help this person. And it's a shame, I guess you don't have IDH1 and IDH2 inhibitors, so testing for that doesn't make a difference, but you should certainly test for FLT3.
Yeah, thanks.
Yep. Dr. Gaballa, any words of wisdom on this case before we close?
No, it's just like, you know, relapse refractory AML, especially post allogeneic transplant, is just a very horrible, you know, disease in general, and it's you know, usually incurable. It's, you know, just it's not a good thing. I mean, I agree. The only thing that may have marginally improved things is, you know, if you do find a FLT3 and, you know, you put them on, you know, FLT3 inhibitor, but then, you know, if you're post allo and you get into remission from FLT3 inhibitor, I don't know if you're gonna, you know, be able to take them for a second allo, and if not, you know, if you're gonna have a meaningful, you know, long-term outcome with a FLT3 inhibitor, they still relapse, at least, you know, from what I see. So it's one of those incurable diseases that it's just, you know, there's a lot of unmet need there.
Yep.
Yeah,
Yep.
that's why I tried to focus on lymphoma. So.
All right, Dr. Alia, any comments from your side on this case?
No.
No, we're good. I think we had a good conversation on it. The reality is MLL rearrangement, FLT3 or not, is such a bad disease. They tend to relapse. I had a patient with this who passed away not long ago. He relapsed, and he was already 2 years post allo transplant, still relapsed. So it's a disease that is for a reason, this category is put in the high risk stratification. And we are seeing something now with the menin inhibitor for them that might make its way. And that means we're talking with our pathologists. Dr. Al-Kawaz will be adding, once that approved, we will be adding that to the tests that we do when we are thinking of using those inhibitors for these populations. As a group here, we standardly check for FLT3 as well as NPM1 up front. NGS is a thing that made life easier, as you check for quite a bit, but we're still going through conversations into deciding which specific mutations should we be testing for, and not using the shotgun approach. But more mutations are coming that makes the NGS being a user friendly test to get more for your test results that you look for in your test, because there's more action that you might build based on those mutations.
Unfortunately, the worst category of patients you will deal with them. This is my topic of my PhD, relapsed refractory AML, comparing hem versus flag. Yeah. The worst category of patients.
Yeah, it's a very difficult group. Is Dr. Mabed still with us?
Yes, Dr. Muhammad, I would like to thank you so much for this very nice discussions.
Of course, these discussions don't happen without our amazing residents who put these cases together, and your all's attendance, so we can share our views on them. I truly thank you all for joining us today, and inshallah, we will plan on doing this again. We have started back, and maybe in another month or two, we regroup again once we have a couple more cases to discuss. Thank you so much, everybody, and have a good rest of the day.
Thank you.
Thank you.
Thank you.
Thank you very much.